Welcome, everyone. My name is Anita Pfeffer, and the title of my PhD thesis is Evaluation of Oncology Treatment Approaches and Clinician Practices for Safety, Efficacy, and Adherence. I have been working at the Pediatric Center to Zoltos 3 department for 2 years, and now I'm a first-year PhD student. My vision is to improve the survival and life quality of oncological patients, and my mission is to identify the least harmful and most effective therapeutical opportunities for oncological patients. Here you can see my two ongoing projects. In my first project, I would like to investigate the therapeutical opportunities of adrenocortical carcinoma, and in my second project, I try to focus on the efficacy and safety of growth hormone therapy for pediatric brain tumor survivals. Let me introduce my first project. The title of my first project is Comparing the Effectiveness and Safety of Available Therapies in Adrenocortical Carcinoma, and we would like to do a systematic review and meta-analysis in this topic. Shortly about the background. Adrenocortical carcinoma is a rare malignancy with poor prognosis. Regarding the treatment protocol, a uniform guideline is not available, especially in childhood and in advanced stages. Our aim is to compare the effectiveness and safety of adjuvant therapeutical modalities. And why is it important? 4 different stages of adrenocortical carcinoma can be distinguished according to the severity of the disease. As you can see, the gold standard therapy in all stages is surgery, but from stage 2, we can choose between different adjuvant therapeutical modalities. But there is a lack of knowledge whether each adjuvant therapeutical opportunity contributes to recurrence-free survival and overall survival. That's the reason why my aim is to investigate the efficacy of these treatments. My clinical question is, which therapeutic modality provides the best survival and side effects? I would like to use the PICO framework, in which population will be patients with adrenocortical carcinoma, intervention, additional adjuvant therapy, the comparison, no additional adjuvant therapy, and the outcomes, mortality, and side effects. My hypothesis is that all types of additional adjuvant therapies lead to higher risk of developing side effects, but increased survival rate in adrenocortical carcinoma. My clinical implication is optimizing therapy, increased survival, and decreased side effects. It could bring direct changes for patients' life perspectives. It could show new way in decision-making for clinicians and propose suggestions for treatment protocols for researchers as well. I conducted my systematic search in the middle of November, and I found more than 17,000 hits. I used my finalized search key, which I divided into 2 domains. The first one is about adrenocortical carcinoma, and the second one about the treatment options in this disease. I found 4 key articles separately about each adjuvant therapeutical modality, but now, because of shortage of time, I would like to highlight 1 key article about each treatment options. My first key article investigated the efficacy of postoperative radiotherapy in adrenocortical carcinoma. The most important strengths of this study are the high number of participants, the subgroup analysis, and the investigation of different stages. To highlight limitations, it's a retrospective study in which the type of radiotherapy and dosage are not available, and data regarding systemic therapies are not recorded. My second key article examined the efficacy of mitotan treatment in this disease. The strengths of this study are the accurate characterization of the patients, the details of mitotan treatment, and the subgroup analysis. There were some limitations, as the retrospective design, the low number of participants, and the lack of well-matched controls. My third key article investigated the efficacy of platinum-based chemotherapy in adrenocortical carcinoma. They used well-matched controls and informed the readers about chemotherapy regimens and side effects. The limitations were the retrospective design, the low number of participants, and the lack of randomization in addition to the relatively small sample size. After duplicate removal, I had more than 13,000 articles, and based on title abstract selection, I have 112 articles. And now I'm working on my full text selection. Here you can see the progress of my first project. I finished the duplicate removal and the title abstract selection, and my full text selection is still ongoing. And now let me introduce my second project. which is the efficacy and safety of growth hormone therapy for pediatric brain tumor survivors based on real-world data, and we would like to do an international survey in this topic. Shortly about the background, brain tumors are the most common solid pediatric malignancies. Thanks to the improvement of the treatment opportunities, the 5-year overall survival rate is over 80% in these patients. Although, as a result of oncological treatments, we often have to reckon with serious endocrine side effects. One of the most common endocrine side effects is growth hormone deficiency, which can be caused by hypothalamic pituitary dysfunction from the tumor itself, surgical resection, or radiotherapy as well. Now, there are well-developed international guidelines for initiation and use of growth hormone replacement. Despite this, several studies show that in clinical practice, the treatment of the affected patients, considering some important aspects, is not carried out in accordance with the current guidelines. That's the reason why my aim is to evaluate the management of growth hormone deficiency and the expert opinion in the clinical practice and investigate the efficacy of the different therapeutical approaches for safety. My clinical question is, how does the different management of growth hormone replacement influence the safety and growth in pediatric brain tumor survivors? I would like to use the PICO framework, in which population will be pediatric brain tumor survivors, the intervention and comparison, the different management of growth hormone replacement, the primary outcomes, recurrent disease and secondary malignancy, and the secondary outcomes, shortfall of height and catch-up growth. My hypothesis is that management of growth hormone replacement, according to the international guidelines, provides the best catch-up growth and lowest rate of recurrent tumors and secondary malignancies. My clinical implication is for patients improve quality of life, for clinicians optimizing growth hormone therapy, and for policymakers optimizing the access to the growth hormone treatment. To summarize, as I mentioned earlier, my most important aim is to improve the survival and life quality of oncological patients by identifying the most effective and least harmful therapeutical opportunities for them. With these two researches, I would like to contribute to achieving this. My favorite quote is from Albert Szent-Györgyi, who said that research is to see what everybody else has seen and to think what nobody else has thought. Thank you for your attention.
Thank you, great presentation. I just have one question. Is there any available targeted therapy other than mitotan in the treatment for adrenocortical carcinoma? Thank you.
Thank you for your question. There are a lot of targeted therapies with a different effectiveness. The most widely used is pembrolizumab treatment, which is a PD-1 pathway inhibitor, and there are other treatments, for example, linzitinib, which is an insulin receptor inhibitor.
So thank you for the nice presentation. My question is regarding your first project. Do you plan to conduct a subgroup analysis based on the different treatment modalities?
Thank you for your question. If enough data will be available, we would like to investigate the efficacy of radiotherapy and mitotan therapy in the different stages of this disease. And if it's possible, we would like to examine the efficacy of radiotherapy in relation to surgical margin and the efficacy of mitotan therapy in relation to the hormone secretion of these tumors.
Thank you.
Congratulations on your presentation, and I would like to ask that what is the most important side effect of mitotan?
Thank you for your question. Mitotan is an adrenalytic drug, so it can damage the adrenocortical cells and it can cause hypoadrenia in a lot of cases. And it can damage the Sertoli cells of the testis as well, so it can cause hypogonadism, and it has a lot of gastrointestinal and neurological side effects, nausea, vomiting, diarrhea, and it can damage the mental and physical development of the children, so maybe it's the most important.
Yes, one more question.
Yes, thank you. So my question would be, is it safe to use growth hormone therapy in brain tumor survivors, or what does the literature say about this?
Thank you for your question. The majority of literature data show that growth hormone replacement in pediatric brain tumor survivals is not associated with higher risk of recurrences, but its use may increase the risk of secondary malignancies. So maybe that's the reason why the specialists have a fear to start growth hormone replacement as early as it is suggested in the current guidelines.
Hello. You said that you can use pembrolizumab for this type of cancer. In Hungary, do you use it for adjuvant therapy or only for metastatic therapy?
Thank you for your question. We use it only in metastatic cases when the first-line therapy is so-on surgery, mitotan, and the basic chemotherapeutic regimens are not enough.
So did you find any articles that were using pembrolizumab in the adjuvant setting?
Yes.
Yes.
Yes.